it is a huge honor today to be interviewing a man on Dentaltown who's a legend with 5,000 posts. I mean, my God, I'm a huge fan of yours for a long time. You've been a member since 2007. You don't look old enough to be on Dentaltown since 2007. I think you started as a dental student, didn't you?
I did. If I shaved, I'd look like I'm in dental school. But yeah, started as a student. Signed up formally, I think, right about graduation time. But I had been following Dentaltown a little bit and got signed up. And I think that summer I came out to the first Vegas. It might have been the first time I was a dentist. So maybe 7-8 months after graduation. And that was kind of my, 2007. That was the year I met Dentaltown.
You know what? I have to chuckle. I laugh so hard because every time I meet a dental student, they're always telling me, "Oh yeah, we just sit in the back row and surf Dentaltown on our iPhones during our boring lectures at school." And I'm just like, "Oh my God, that is hilarious." So, I mean, what I wanted to get you on is you're legendary in your anterior cosmetic work, your direct composites. I mean, would you say that's your forte or your main focus?
I'd say it's my wheelhouse. It's what I have the schedule, and then I have the anterior case. Everybody out, be quiet, it's go time. That's definitely my forte. It's what I enjoy probably the most as a dentist. It's one of the things I enjoy most. I mean, outside of spending time with family and loved ones, it's pretty much a hobby. It's an addiction. It's something that gives me my, I guess, kind of my art fix now, which is nice to have that at times during your career, to have something that is on that, that somewhere it's got a passion center and a happy center. So when I do anterior resin, it makes me happy. I really enjoy it. I have a bit of a artistic side of me, and I think it comes out with anterior resin more than anything else in dentistry.
I have to admit, I love dentistry too, and I love family. I have 4 boys, and I was so excited because this morning I won by 2/3 majority the Outstanding Father of the Year award. And but we had one. No, I'm just kidding. but anyway, so I want to start with I like to talk about not what everybody agrees on. I like to I always say success is about how many uncomfortable conversations you're willing to have. So let's start with the most uncomfortable conversation in your wheelhouse, and that is if it was your own child and they needed veneers, would you do direct composite or would you reduce tooth a millimeter and do an indirect porcelain veneer? And what do you think of laminates where you don't reduce anything and you cement a fake fingernail on the front of the tooth? And a lot of dentists say, well, I'm not going to do that because it thickens up the tooth. And I'm like, but this girl already has augmented boobs. She has clown makeup all over her face. Her hair's got all kinds of chemicals, wax, mousse. Am I being weird of preserving tooth structure? What would you do if your wife, your sister, your mom wanted her $1 million movie star smile? Would you do direct composite? Would you do laminates on unprepared teeth, or would you reduce the teeth 1.5 millimeters and do indirect porcelain veneers? How's that for an opening question?
There you go. Big discussion. Big discussion. I think every case is different. You'll hear that all the time. Dentists say, oh, every case is different in my hands and that kind of thing. Largely, it's if they're a young patient, I'm more comfortable with direct. If they're an older patient, I'm more comfortable with direct. That's just me and my wheelhouse.
So you said younger, direct.
Both direct.
Both direct.
I like direct. Direct to me is, I mean, you'd probably be surprised how little I put a burr to a tooth for anterior stuff. Usually I don't have to. A lot of times I'll do veneers and I'll just grab the most bulbous line angle and let's just leave that as the distal lobe and do a 3/4 veneer off a distal line angle and rotate it out. You can always remove tooth later if you have to. I think it's better, if you're going to remove some tooth structure, if they're over 40, the pulps are starting to get smaller. I think, you're going to set that tooth up to hopefully see them through life. I think if you go indirect early on and to reducing tooth structure, you're setting that tooth up, 50, 70 years down the road to maybe a questionable prognosis. That's just my hunch. There's times when I think, you kind of need to do a crown, or you maybe need to do a 3/4 crown with some of the risk factors and that kind of thing. But I tell you what, I had my aha moment with direct actually came from a Dentaltown guy named Tiff Korishi, who did the Inman Aligner
Out of London.
CE on Dentaltown. I took that, and he's also really good at class 4s and sizel edges and bleaching and bonding. And he showed me cases that I thought were impossible without going to really using some kind of lab fabricated veneers, where he would whiten teeth, align them, usually with an Inman Aligner. Sometimes even intrude or extrude a little bit, and then he would just do whitening, and then he would do really nice composite resins to finish off shapes and colors and that kind of thing. And I couldn't get over it. Really, you're not touching these teeth with a burr, or you're not, it's just something that was foreign at that time. That was a couple of years ago, where that's really become what I think it's a good way. I think, the less is really, if you can do less to a tooth, the better it is. At least in the front, and then putting risk factors aside.
And when you get excited about an anterior composite case, what kind of case are you talking about? Are you talking about like indirect veneers, or are you talking about just class 3s, class 4s, interproximal decay? What cases get you the most excited?
Composite veneer, the whole tooth. Probably the most excitement is a single composite veneer to match the adjacent central incisor.
Okay,
That's the one.
So my number one complaint on podcasts is you don't do enough. I think the reason podcasts are going to explode is because, when we were little, we had a weird behavior where we could sit in a chair and read a book with no pictures, and most people just weren't readers. And they'd always say when we were little, all readers are leaders, all leaders are readers. But now I think reading has exploded because of Amazon and iTunes, and now little kids are doing audiobooks while they're riding their bicycle, or they're playing, or they're on a treadmill. And most of my fans, about 7,000 dentists, are listening to per show now, and they all say the same thing. I got an hour commute to work, so they want more podcasts. If you do, they got an hour drive to and from work 5 days a week, so they want 10 a week. The second biggest complaint, and I want to throw that on you, is they go, be more specific, like what composite, what bonding agent, what. So why don't can you just sit there, and I don't want to bore you to death, but can you walk through for my listeners just the infinite detail from what type of burr, what type of bonding agent, and just walk us through an anterior direct composite case?
Oh, sure.
Let's do it. Let's do it.
All right, pick what happens to a tooth. Let's say you want to do how about a broken down big class 4 number 8, and it's discolored. You want to do that one?
Absolutely.
Let's go for it. All right, number 8's discolored, broken down. They come in, and let's say you have an hour to get this done. They come in, it's broken down tooth. Let's say it's even endo-treated, but still you have a lot of tooth structure left where you don't need really, you're not. I think anterior teeth, do really well. I like to put off crowns. So we're going to go right to a composite veneer. First thing I'm going to do is numb them up, rubber dam, go to a Siltec putty. I sometimes will double up on the hardener when you mix it to make it set a little bit quicker. You can do a Siltec putty with a broken tooth. Okay. You're not going to build up the tooth and do a putty stent. You're going to leave the tooth broken.
Okay, my job is to estimate questions that the listener's having so that they're not alone. What's Siltec putty?
Siltec putty is, I believe, he manufactures it. I'll have to add that as a
polyether, a polyvinyl, an impression material, a ball, or
it comes in a jar. It's the got the canister. Yep, it's like a putty, except it's very accurate. And then instead of a putty with another putty, it's a putty, and you add a gel hardener. And so you mix the two together, and then you hold it up palatal and also the incisal in the broken part of the tooth. And after about 2 minutes, it'll set up fairly firm, but it'll have a little bit of flexibility.
And why do you want this?
And you do this, so now you have a palatal matrix of the broken tooth, and you have an incisal shapes of the adjacent teeth. You then cut off at the facial plane all the stuff above in front of the facial of the incisal edge, and you approximate it on the broken tooth. So now you have basically just the palatals up to the incisal, and then it's off. You then take a football composite burr that I think everybody has, It can be any number of flutes. I think mine are 10 flutes. And then you actually drill out in the putty that broken piece to make it look like the adjacent tooth. And so you're doing some work in the putty, and the patient's sitting there. The more you can do away from the patient, the better. You then bring that putty over, line it up, take a look at the shape in your putty, and if you like it, you put Teflon tape on the two adjacent teeth, etch your tooth, or go ahead and maybe remove, maybe 4/10 of a millimeter on the facial, or 3/10, just a little bit of room to opaque it out if it's a dark tooth. And then you go ahead and etch, prime, bond. I use Total Etch with OptiBond FL.
That's correct.
And then you go ahead. That's what I like. Then you go ahead and then you then you have now a bonded tooth with Teflon tape on both sides. You leave the Teflon tape on the adjacent teeth, bring the matrix back over, and you're going to take it off and you put in a palatal posterior composite that is going to then start working the palatal enamel. That's called your palatal shell. You'll kind of take that on the matrix, stab it there, bring it up behind the teeth, and then you kind of connect it to the palatal enamel on that tooth. You go ahead and cure it 10 seconds with a velo light, remove it, and now you have a palatal wall. So now you have your broken tooth, a palatal wall. And then I use a BioClear posterior, actually. For me, they work really well to go ahead and approximate the broken edge. And I'll place a BioClear, or you can use an Anterior, but I like to cut it back a little so I can get in and work it from the facial versus the incisal as they're designed. Then I'll work it from the facial, use a BioClear as my proximal matrix, then I'll go ahead and cure that. And again, it's usually that palatal enamel shade. Now I have the outline of the tooth already ready to go for body shades. At that point, I typically almost start to finish use Cosmodent for everything for the anterior, Cosmodent tints, microfill for the facial, and I'll usually then use a nano of the color I want to use, A2 nanofill, and that'll replace most of the dentin. At that point, I will then use this color A2 microfill and replace most of the enamel surface, but I'll leave some room if there's some mamelon development or a proximal that looks kind of that achromatic, just enamel shade. And I'll leave some room for incisal light microfill, and then I'll go ahead and apply that as well, and then cure. And then just you go to polishing and shaping a little bit.
Okay,
so that's my technique.
What percent of dentists have never used the putty? What did you call it again?
Siltec putty.
Siltec putty. What percent of dentists would you say have never used Siltec putty or for that technique or the Teflon tape?
I don't know. Oh gosh, maybe 20% have never used Teflon or have used Teflon tape. Sometimes I'll say Teflon tape. I can't go a couple hours at work without Teflon tape or something. And people will say, "Well, what do you mean?" But yeah, I use Teflon tape a lot.
Yeah, so I believe you're correct. 4 out of 5 dentists have never used Teflon tape. So explain what Teflon tape is. Where do you buy it, and why do you use it?
Teflon tape, plumbing aisle, Home Depot. There's 3 or 4 colors. You just got to get white. Don't get the real thick stuff because then it's too thick. Just the I think it's 5/8 inch thick.
And plumbers use it because if you put it on the grooves, when you screw in the grooves, it seals.
Exactly. It seals. So it works really nice. If you can floss a tooth, you can sneak in a whole piece of plumber's tape and cover the tooth in Teflon. But it's watertight. So if you have etching on a tooth next to it, you dry it off, remove the Teflon tape, and that tooth has never been touched. You can also use it, you keep a tooth covered with Teflon tape for a little bit, it'll prevent it from dehydrating. So you can kind of check color.
So you like the Teflon tape so you're not acid etching and getting any bonding agent on
exactly
the
right. And it gives you just a little room, too, when you remove it. Just a little room to sneak a Mylar or a BioClear or something else in, which is nice. It helps keep it clean.
That's an incredible pearl. And why when dentists don't use the Siltec putty, what are they having to do? They're having to freehand shape it all from scratch.
Likely, yeah. You can use any bite registration, and it may not handle as well, but you can do the same thing with any bite registration, or probably even a medium body PVS would get you at least in the ballpark. You might have a little more give in it, so you're off a little bit. But any of those are probably going to get you in the ballpark closer than freehanding. Freehanding is a little difficult on a large class 4.
Okay, and I have to keep asking questions. You dropped 2 words that they might not understand. First, why did you pick Cosmodent when there's probably 100 composite companies? And when do you use a nanofill versus a microfill?
Cosmedent, first off, I like Cosmedent. They have probably the highest, longest lasting polishable composite in their microfill because of the way that the filler particles are universally small. But yet it's a beautiful material. It really replicates enamel shine and enamel properties very well. They also have a shade called Incisal, which is just beautiful. If you add it to some of the areas of the enamel in a way, and you shine light from the sides, it'll kind of iridesce, almost like Dentin will sort of iridesce from angles, like kind of have that sparkle to it. It'll do the same thing. It really adds vitality. The second question is nanofill is a typical of a posterior composite because it's got bigger particles that are nano size. And in addition, it polishes pretty well, but mainly it's a durable composite. Your microhybrid's probably your most durable composite, and also a very, very suitable palatal shell. Or if you're doing one of those guys on a front tooth that keeps on chipping a small chip, a microhybrid might hold up a little better than anything else. And those are all from Cosmedent, and their website's great. It's a great company.
It's got a lot of tutorial videos on their website.
Yeah, it's got about 50. Absolutely gorgeous Cosmedent tips of the month with fantastic clinicians. And so it's a good company. They have their products that they sell at very reasonable cost. Then they also have a lot of videos how to use their products to a very high degree.
And what's
so
amazing
it's really nice.
Is Buddy, who's the owner.
Buddy Mopper's terrific.
He started as a pediatric dentist.
Right, he did,
Go figure, one of the most cosmetic dentist legends started in pediatric. Carl Misch started in removable dentures.
Really?
And then he became an implantologist. So speaking of videos...
Yeah, as good as a guy with lower dentures, he never seemed to work well,
Well,
there you go.
What got him frustrated is when I think he got most interested in implants is when all these people were saying that the implants weren't strong enough because they kept breaking. And he's like, dude, that's because you don't understand the denture you put on it. You got to get the denture right, and then the implant helps support it. You can't have a completely malocclusion denture that doesn't fit right. Right. And then hammer it down with titanium. You got to cross train. You got to know the removable and you got to know the fixed. And you just can't be a fixed prosthodontist and have no clue what removable is, and you can't be a removable guy and understand fixed. Well, you got a course on Dentaltown. Talk about your course on anterior composite dentistry.
Yeah, along with two of my good friends, Matt Costa and Arthur Volker. Matt Costa is from outside Lancaster, Pennsylvania, and Arthur Volker is he's in Queens, New York. The three of us have a course coming up October 10th in Quarryville, Pennsylvania called The Daily Grind, Maximizing Outcomes with Composite Resin, where we're going to go over our techniques for posterior, a little bit on smile design, and then also anterior composite. And it's going to be focused on hands-on. So you're going to work on mannequins, and we're going to have an instrument package that's going to be yours to take home, so you can do exactly what we do at the course when you go home and work on your own patients. So I'm pretty excited.
That's you and Artie?
Yeah, Artie. You've met Artie.
Artie Volker?
Yeah.
Volker. And who's the third one you said? Matt
Costa, Costa.
And where's Matt from?
He's outside Lancaster, Pennsylvania.
Okay.
Quarryville, Pennsylvania.
And what's confusing, there's a Mark Costa too.
Okay.
Yeah. Do you know Mark?
I don't know Mark.
He's more practice management.
Okay.
And organization. He's one of those guys that comes in and every operatory, everything is exactly in the same place. Well, I'm excited about your course. Now,
I'm excited
Is it a hands-on participation class or is it a lecture class?
Yeah. We're going to do a morning and an afternoon lecture. The morning lecture Matt's going to give for about an hour and a half on really posterior composite design or cavity preparations, the importance of why you should be conservative, how to be conservative, the importance of peripheral rims of enamel, class 2 design, and then he's going to do a class 2 hands-on where we're all going to help teach that to the participants for the rest of the morning. So that's going to be the 8 to 12. From 1 to 2, Artie's going to go ahead and share about smile design and some cosmetic things for smiling, for movement of teeth, a little bit on orthodontic appliances and that kind of thing. And then he's going to segue into really the tooth design, which is what I'm going to take over. How do you understand how a number 8, number 9 look together? How do you do certain parts of number 8 or things like that? How do you do a class 4 and that kind of thing? I'm going to then go ahead and do a step-by-step class 4 for the hands-on for the afternoon. So we're going to go through a multi-layered class 4, and each participant's going to learn how to do it. And there's a lot of tricks, and there's a lot of things that it'll speed up your learning. For instance, like a Mylar pull. If you've never done a Mylar pull, it's a huge trick, and it's really simple, but you have to see it to do it. And things like that. And there's a few tricks to understanding the adjacent tooth really well. Oh, that's how you can quickly copy that part of that tooth. So there's a lot of these little tricks that are very helpful to learn. And also the instruments are different, and the way you apply composites very different. If you haven't seen how it's done, if someone's only done, compules of composite, and they never placed a ball of composite and pressed it to where it should go and used a brush to smooth it, it's very different. So some of these hands-on portions, we hope that people really mess up. Hey, it's better to mess up with us, where we can show you, here's how you can correct that. Let's practice this movement a few times. So that's what we really want to do, and we're all very excited.
So is this your first one, excited. The three of you?
This is the first one, the three of us. Yeah, we're kind of a new little think tank group, the three of us. We met up.
That is so awesome. And you met on Dentaltown.
We met up on Dentaltown. Yeah, that's how.
That is awesome. If you ever want to do one in Phoenix, I'll promote the logistics for it in Phoenix. We got 3,600 dentists in Phoenix, Arizona. If you ever want to do a hands-on deal, or maybe you should do that at the Townie meeting sometime.
Hey, let's do it. Let's do it.
I think the three. Now, I've interviewed Artie, but we were rushed. We were at the Grand Hyatt. I only got 20 minutes with him. Send Matt my way. I want to.
Yeah.
Tell Matt to do a podcast.
Yeah, you bet. You bet. He's a great guy. He's so good. I mean, Matt's my friend and everything, but he's just a mentor in a lot of ways. He's a little bit ahead of where I want to be as a dentist, and he's been great. And when we kind of formed the three of us as a group, we said the first reason is that we can each become better dentists. We're held accountable. Secondly, it's, to teach something, you've got to know it. And thirdly, we get along really well. There's a lot of jokes, a lot of fun texts.
So
in this
thing. Where can a listener find out more of this? Have you guys got a website up?
We don't have a website for the course. The easiest way is just on the Dentaltown. We have a thread. I think it's got about 165 posts up about any interest in a course from Steve Kuzmak, Matt Costa, and Arthur Volker. And that's the easiest way to do it. It's people are talking a lot about it, so it should be up in today's topics and that kind of thing. And you can also look up either of us on Dentaltown.
And what's the date of that? October what?
October 10th, Saturday, October 10th.
In what city?
Quarryville, Pennsylvania.
Quarryville, Pennsylvania. Well, where is that near? Howard Goldstein's in Bethlehem, Pennsylvania.
He's in Bethlehem. He's probably about an hour and a half north.
Is he going to go to the course?
I don't know yet. I don't know that I've heard from him.
Yeah, maybe. He's
a good guy, though. I'd love for him to come down.
Yeah, maybe. Hogo can go, and maybe I can get out there. I don't know what my date is on October 10th, but I just think that would be rocking. I'm so damn proud of you guys because I'm a huge fan of your 5,000 posts, and it's not only are they informative and educational, but you're always fun. You guys just exude a lot of fun and karma. And I watched some big fight with Artie at a bar in New York. I forgot the fight.
Probably the Mayweather Pacquiao.
Yeah, it was the Mayweather fight. It was the Mayweather fight, and it was so funny because everybody was so obsessed with this fight, and there was 4 dentists having beers and not talking
about the fight.
And I don't think anybody even watched the fight. We were just, it was just so damn fun, the energy. So I'm gonna talk about more uncomfortable stuff that you don't want to hear about.
Sure.
Rubber dam, come on, really? That's anal. Are you being anal, dude, using a rubber dam?
Yes, yes, you could say that. It really, you're not going to use it unless you see the benefit. The benefit, sometimes you don't see right away until you use it. You're going to notice things like, actually, I'll tell you sometimes I don't use a rubber dam, I'll use an ISO dry, and sometimes, you're in a rush, and I have a medium volume PPO, and you just got to get something done in almost no time at all, and sometimes, you get it done, But I use rubber dam a lot more than I used to because I want to get somewhere that I'm not. And so the rubber dam is a vehicle that in order to get, I mean, and you know this, I mean, I've read a lot of things about you. To get where you want to be, you're going to have to do something different. You can't do the same thing. So you're going to have to change protocol. And that's hard. I mean, if you talk to dentists, I mean, a lot of dentists don't want to change a protocol. That's, oh, this is how I do things. But for me, about 6 months ago, really focused on using it. And I remember going a few months back, where I told the staff, I am not going to do anything in the mouth without a rubber dam. Anything. If I'm going to polish a tooth, rubber dam. And so it was a neat week. You realize, hey, 3 of my 10 best crown preps were that week. 5 of my top 10 posterior composites were that week. 2 of my anterior cases that I thought were the best I've ever done were that week. So a lot of things will get, if you did like a rubber dam challenge, just do 1 week rubber dams, you'll kind of notice some of my best work was that week. Can I do this all the time? Was I going slow? Well, maybe early in the week I was going slow. But if you want to get really, really good, you're going to have to change protocols. And so some people that might be, going from not using anything to maybe just a rubber dam clamp, if that's their next step for some isolation, or if they haven't done anything like that, just going, to an iso-dry, that might be the next step. Eventually you'll get where you'll see the rubber dams more comfortable than the isolite. And I didn't think that would happen, but it is. You'll have less people complain about it.
Okay.
And you'll also realize you like it more because you can see everything very clearly. And it's enjoyable. It really is. Very enjoyable.
Sorry, I have to blow up my nose. I swam my Ironman distance this morning in the pool, 2 hours and 18 minutes, 2.4 miles. So I have about 88 gallons of water in my sinus.
That's impressive.
There's somebody listening that doesn't know what you mean by isolite.
Right.
I'm always trying to guess questions. So
Sure.
You just said rubber dam isolite, and I think 2 things people might be questioning is, what is an isolite, and number 2, when you're doing an anterior case, do you punch like 10 holes and clamp second bite to second bite, or are you one of those dentists that makes a 1-inch long slit and then just and the rubber dam's more like to hold back cheek and tongue? And
there are times you do both. And there's plenty of times where you just do 1 hole. 1 hole. I'm going to do a cervical part of a tooth. I already know I'm going to use A3, and you can do a 1 hole and kind of treat it like an endodontic, and you can use a 211 or a 212 clamp, and really, get a nice cervical isolation, and it's really easy. You can relax. You can do dentistry with 1 hand and just relax. Saliva's not going to get there. But
explain to the listener what an isolite is, and when do you use an isolite, and what percent of time do you use an isolite versus like a rubber dam, or is there time?
I probably use the isolite when I'm doing sealants, or just some small things, a couple of them throughout, a number of 15 lingual pit, or some, usually no anesthesia. If I'm going to get them numbed up, I'm going to go to rubber dam. If they're just some small areas, sometimes I'll use an iso-dry. I don't use the isolate with the light. I just use the iso-dry on a Kona adapter. And to say what the isolate and the iso-dry are, it's manufactured, I believe, by Isolite Systems. It's 2 pieces of clear plastic, one that kind of goes around the tongue and the roof of the mouth area, and then it gets thin in the back of the mouth, and it gets wide again for the other side and holds the cheek back. And then the roof of the mouth extension wraps to the other side and has a bite block. And so it can hold back the tongue and the cheek from both the upper teeth and the bottom teeth on one side of the mouth. So it's nice to have. But if you're going to do it, but if I'm doing a quadrant, for instance, 18 to 22, or I'll get in some kind of work, class 2s especially, I mean, nothing's as fun as a rubber dam. It takes a minute to get it on. It doesn't take too long. You then floss tie some teeth to really hold it down cervically and get a nice seal. And it really, you can see clearly, and you can take your time.
Do you like those rubber cords? I don't know the name of it. Where you
wedge it, the yellow guy or the orange guy, the wedge it.
It's kind of like it's like a 2 millimeter thick floss rubber, but you stretch it, it's thin enough to pop through, then you let it go. And
exactly. You use about 1.5 inches to hold the rubber dam down in its most anterior spot. And you can get them from Ultradent or from Pearson's, probably from most of the larger companies will have. It's called wedge it. You
opened up a can of words, but you're the one who said it, not me. You said sealants. There's a lot of people in Dentaltown that post really good studies that say 40% of sealants have failed at the end of a year, and at the end of 2 years, they're almost all failed. What do you think of sealants today? What are you using sealants, and what do you think? Have you seen these studies where a lot of people are saying that after 1 year, half are not working anymore, or leaking, or
Oh
failing?
yeah.
So
Oh yeah.
what is your thoughts on sealants? Do you still recommend them for if your 6-year-old daughter came into you and had 4 virgin 6-year molars pop through? Would you put sealants on?
No. No. I haven't done sealants on anyone under. I mean, I call them sealants, but I mean usually they're stains at a periphery of a composite, or they're no. I don't do too many sealants on adolescents and kids. They can work if done well. I think there's a lot of wisdom in using something that's glass ionomer based, and I think a lot of the small things, the sealants I do, they're more on dentistry that's there than a tooth that has never had anything. So it's a lot of times it's an edge of a filling that needs to get resealed because it's
Okay,
soft.
back to your own kid or your niece or nephew. What do you think about blowing out the pit and fissures on a 6-year-old girl? 4 6-year molars are in. What do you think about the preventive resin restorations where you'll go in there and take a diamond and clean out the pit and fissures, and you're usually going to always be indenting, and then doing a colloidal composite to prevent future decay? Do you think that's too aggressive? Do you think there's a place for that? What are your thoughts on that?
There's a place probably for it if you do it really well, and if risk assessment is what's driving you. A lot of times, the higher risk caries are in Medicaid and lower income areas. My kids don't really know what soda is. They don't know what juice is. It's just different.
Yeah, but you're Ukrainian, so you're giving them vodka, and that can cause decay too, right?
Yeah, there's a place for it. I don't know enough about 6-year-olds and risk assessment and that kind of thing. You'd have to probably look at a lot of pedodontists and get some really good feedback. But then you'd have to go to different areas too. There's kids that tolerate a lot of things to be really well done, and then there's kids that they can't sit still and that kind of thing. But I don't see many kids. I mean, I see maybe
it seems like the
10 kids a year.
California dental schools are the only ones really getting behind caries risk assessment, because you just mentioned a lot of variables: socioeconomic, education of parents. There's so many variables. Have you been seeing that at California dental schools where what is that caries risk assessment system they're using? Their big promotions of.
I'm not too sure. For me, it's just common sense. I mean, I always think if I'm putting in dentistry, it's going to be more prone to becoming a cavity than nature's enamel for the most part. So I don't do a lot of them, but if I do a small PRR or a sealant, you got to have something to keep it dry during the entire procedure. The other thing is I go back to Teflon. You can put a little Teflon when you have a little operculum. If you go gently, you can put a little Teflon tape back between the operculum area and the tooth and get it dry. I mean, so you can do them well, but I don't see many kids. I just don't. In my area,
So describe your practice. You're TowsonView.com in Towson, Maryland. Is that
in Towson? Towson. Towson.
Is that a suburb of Baltimore?
Yeah, just north of Baltimore.
So what was it like going to the first dental school in the United States of America?
Hey, it's a good school. Really, really good school. Can't complain. Came out, graduated. I was ready to be a dentist. I didn't think I needed to.
What year did that school open? Do you remember?
I think it was 1840.
1840. Wow, that is amazing. So So what we're 35 minutes down. I only got you for 25 minutes. What do you think these 7,000 listeners? What other things do you want to talk about? You think it'd be the best use of your time?
Best use of my time. I would just say to think of dentistry in some ways. You want to be happy at work. And to me, and probably for you too, there's a component in my head that says I'm happiest when I'm growing as a person. Maybe it's not professionally or maybe it's something else, but when I'm growing as a person, specifically when I'm doing something that I used to not be able to do. And that to me is really fun. I like to sometimes think of myself in 3 parts: my past self, my Steve you see today, and then my future self. And, I'll sometimes think, my past self couldn't couldn't do that crown prep like I could today. And I'm excited because I know my future self will one day be able to do a crown prep that I can't do yet today. Same thing with composite. I'll do a front tooth and I'm like, you know what, but in 2 years, I'm going to be able to be better than who I am today at this. So I've picked some things in dentistry, not everything. I don't know that I'm getting better extractions. I tried, but I think it's very good and healthy for people's well-being, specifically for dentists, because it is a stressful job, to kind of have a component of dentistry that's for you. And by that I mean it's not for the patient. The patient's going to benefit, but this is for me. I'm doing this for my own development, and that's something that kind of will change your perspective a little bit as a professional. You're doing the right thing, but you're doing it to achieve a level that your past self couldn't do, and it's stressing out you now. But you're going to be better as a person, and you can add something to your. You can walk around town. Hey, I can do something that I couldn't do 6 months ago, and that's a neat feeling. You can get it, and you can definitely get it with dentistry. You can get it too through art, music, weightlifting, athletic events, Ironman training, all these other things. But that's a very healthy thing, I think, for humans. And the second thing I would say is, do what's right for the patient. Patients will respect you for doing really what's right. They may not like it while you're doing it. And sometimes patients don't like isolation in their mouth. They just want a soft piece of cotton candy, and that's all I can have. But, I had a lady yesterday. Oh, don't put me back. I get dizzy. And I'll say, are you okay, though? Yeah, I'm okay, but don't put me. Well, I need to put you back. I want to do my absolute best job for you. And it's going to really help me out to put you back. Oh, okay. Well, just put me back slowly. And so you can kind of think that, this is for me. I want to enjoy this career as much as I can. And most dentists are, doing okay financially. I feel bad for the newer graduates with a little more debt, but that was kind of what I would say. Try to pick at least one spot in your career that's for you, and that's kind of whatever it can be. That's what I would say is to go with that thought.
Well, you're an outstanding teacher because your positive energy and karma and enthusiasm just exudes from every corner of you. Really.
Yeah. Thanks, Howard.
Yeah, but I don't know if a lot of my thinking. I'm sure a lot of it has to do with my mother, because I never saw dentistry as a job or an occupation. I saw it as a vocation. My two older sisters left high school and became nuns. My mom's goal for me was to be the first American pope, and all the popes were Italians, and she wanted an American pope. And I think I brought that childhood into dentistry because I always see it as a vocation. Mother Teresa didn't get paid to do her job, and being a successful $1 million practice is a side effect of just wanting to do a good job and loving what you're doing and totally committed to it. And my boys say that my lifestyle is that of a monk. I don't spend any money because that's not – I don't do all that to go buy a jet ski or a condo or a vacation escape. Probably everything I do is just either two subjects, my 4 boys or dentistry.
Right.
I only have 4 boys and a granddaughter, I'll say. So I want you to also explain you're humble in that you give a lot of credit and you talk fondly about Dr. Ed, Lane, Doc Terry. So tell these viewers, because a lot of our viewers have never even been on Dentaltown. So you're probably talking to a couple thousand people right now that have never even logged on to Dentaltown. So why do you talk so fondly of Dr. Ed, Lane, and Doc Terry?
Oh, there's a bunch of them. You can almost go through what have I learned from Dr. Ed? He's a big rubber dam user. He crown preps against a rubber dam clamp. That's his trick for why his lines look so smooth. One of them. I've learned class 2s a lot from Dr. Ed. Also Corey Glenn. I learned his wedge technique, where you place a wedge and then you kind of prep your class 2 to the wedge and you can see it really clearly where you're going. But Dr. Ed's a big mentor to a lot of us a lot of us townies. Lane's probably one of the craftiest, most intelligent prosthodontists in the world. He's in 90210 and still has film radiographs. He's not even digital in 90210, and that just means you're something. It means you're something. So he's really good. I really enjoyed his color CE on Dentaltown. Doc Terry, I've learned a lot of push resin to push it hard. Posterior resins, the microhybrids, or he uses Z250. He does these full mouth makeovers with with resin, and he shows 8 and 10 year recalls and
Okay, then
15-year
I'm gonna throw you the biggest comment that Dr. Harry's always gonna get. Well, how long is that gonna last? Because in the dentist's mind, if it's not a PFM or a full crown or an indirect veneer cemented, so what do you say to all those dentists? Say, oh yeah, it looks great, it's unbelievable, massively conservative and gorgeous, but how long is that gonna last?
The only way to say this is I once in a while will get somebody to do a free case, not for charity, but if I'm doing it for free, it's, again, for me. I don't care how they're feeling. And I'll tell them I'm going to take my time. I'm going to probably get you back and touch it up. I'm going to take photos. And so once in a while, I'll put something on Craigslist. Hey, I'm looking to do a free, composite veneer case for marketing and for photos and that kind of thing. And what's funny is how often will somebody – now think about this. Somebody will say on Craigslist to me, I have bonding, needs to get updated, starting to look bad, was done 30 years ago. And you just let all of these risk factors, they're on Craigslist, in the health and beauty, and okay, so they're not even going to a dentist for it. They're not, so you have these things, if someone's on Craigslist and looking at dentistry things for free, they're probably not going to a dentist. They probably don't have the best home care. And yet this was done 30 years ago. So I would bet you, take out parafunction for some of the stuff. I'll bet you a lot of these things will last longer than you think. I think if you say 10-year on average, I think that's probably maybe toward the low side. Some of the small stuff will happen though, where you get a small chip on a composite veneer, but that's because your microfill or your delicate material got too far to the edge and they could catch it in an excursion. So you get a tiny chip. Very simple to repair. But I'll bet you it lasts maybe not quite as long as a crown, but when you're redoing a crown, you might be going to an implant. When you're redoing bonding, you might be going to a crown. So you can look at it that way and say this stuff lasts twice as long as a crown because you're going to get one life out of it, and then you're going to go to a crown or you're going to go to something else. That's kind of what's nice about it. If you can put off a crown another decade, hey, do it for the most part. But I think it lasts really well. I haven't seen anything yet fail. I've seen a few stains and a few things I've improved and a few small microfill chips, but I haven't seen, for instance, old composite veneer, shear off or anything. And I'll push them a bit.
I want to change subjects completely. A lot of dentists, they think before they're going to do an anterior crown that they should whiten the teeth. They should get them in for cleaning and bleach. And then a lot of them think that you need to step back. Like, okay, if I whiten your teeth, and I don't want to do anything today because it's going to step back, and 2 weeks later it's going to be dark, halfway dark again. Will you talk about those issues that they're worried about? Yeah, sure. I mean, if someone, you have to ask that. But you certainly have to ask that if you're going to do a single anterior crown. You better know what shade they're going to end up at for long haul, and have and don't use some powerful bleaching to get them there. You just use a couple of white strips and just bleach up a little bit. That way you're at a level that's easily attainable if they, for the long haul. A couple white strips. You mean the Crest take-home white strips? Yeah, just Crest white strips. Something that's easy from the pharmacy. I mean, I recommend that a lot. We do in-office bleaching. I do just opalescence and custom trays for an affordable price. That way they can continually do it. But you'd be surprised. I mean, A1 blends with fairly light teeth and with fairly not quite that light teeth. It's just a great shade. If your contour is right and your effect is right, the way it reflects light, off your teeth is believable and a mirror image of the adjacent tooth. A1 is going to go with a lot of teeth. A1, A2, and A3 are going to be your bulk of your anteriors. I have a lot of bleaching addicts in my office, so I sometimes will go to a B1. But a lot of A1s are going to blend, whether they bleach a little bit or they kind of revert back to their shade. So, yeah, you'll have to think about those things. Address this. A lot of people are wondering. Some people say that to really get this right, the operatory needs to have a window so you're getting natural light as opposed to lights from fluorescent bulbs. Some dentists will go as far as to take out their fluorescent bulbs and put in special bulbs that have it's 550 degrees Kelvin and this. Yeah, I've heard that. And Lane wears blue scrubs. He says, your yellow visual acuity is best after looking at blue. And so he wears blue scrubs. And I wear blue scrubs as well, but just because
blends
Okay.
with every. I mean,
Okay,
blue's
you
a
said that
common
way
color.
too fast. You just blew my mind. Explain why he wears blue slower.
Lane Ochi wears blue scrubs, and he has said this, I believe, on his Townie CE, because when you look at blue and then look at yellows and white shades, your acuity, your color ability to see is actually heightened a little bit. If you look at blue and blue and blue and blue, and then look at a white wall, you'll see that kind of a yellow tint. So it heightens, I guess, the way the cones are in
Wow.
your eyes for yellows, and so you can see the color a little bit better. But I'm lucky. My operatories are almost right by floor-to-ceiling windows, and so we have a nice northern light kind of coming through all the time. And it's, but you have to kind of, I look at it with, under this light, under the lamp from the operatory, how's it looking against the window light, and that kind of thing. Yeah, you gotta take a look at colors a bit. And there's a few other ways to look at color, but the easiest one is going to be if you're doing composites, to make composite shade tabs. So take an A1, make like a denture tooth shade tab out of your composite, and then hold that up. Or you can do a combination. I'm going to do a A1 and my incisal-light enamel shade on top of it, and then you make that into a nice shade tab, and you can hold it up and look. And so that's probably how I do a lot of colors.
So a lot of your
teeth.
colors. So instead of using the shade tab, you'll actually take a compule and squeeze it out and make a tooth and cure that and use that as a shade tab.
Yeah, except it's a step further. I'll take a denture shade tab, your Avita shade tab, take off just one, put it in a putty and make a model of it, and then take off that tab, the denture tooth, put it back in the putty, and then fill it all up with composite, and then shape it, and then cure that, and then you have a composite, on a shade tab, and then you spend time polishing it and adding some morphology. So you have a fairly good morphology of a central incisor, and then you can use that edge to edge with a number 8 or number 9, and then get an idea on, is my composite shade A1 similar to your tooth shade A1? And that gives you a little more info than looking at a Vita shade A1, because A1 between manufacturers is quite different. It's just quite different. So you have to know your own shades in your office.
But you primarily use Cosmodet.
Yeah, and partially is because if you have one manufacturer, you can learn it really well.
I want to ask you some more uncomfortable questions.
Sure.
And I just love interviewing you. A lot of kids are walking out of school and they're saying, I'm $250,000 in debt, and now I need to buy. Do I need to buy a $150,000 CAD/CAM machine? To be a great dentist. I mean, do they need to almost increase their debt another 60%? What's your thoughts on CAD/CAM?
It's probably great. I don't have it. I don't haven't used it yet. I don't have a CEREC yet.
What about your two friends, Matt and Artie?
They both have CERECs. Yeah, they're both doing some beautiful CEREC work.
So
they really love it.
So you're a class example that you can be a great cosmetic dentist and not have one, and then your best friends and buddies Artie and Matt they do it.
Yeah.
So talk about that. So why do you not have one?
Because it costs $150,000, and I'm still a fresh graduate, and you can get a used CEREC about $30,000. But again, for me to get good at CEREC, I'm going to have to also learn how to tint a CEREC crown number 8. You can't mill a block, put it on the tooth, and expect it to look right. There's a lot of finessey things to tinting out a CEREC indirect restoration that learning composite tinting and such will help you. Probably one of the best in the country is Gregory Mark up in he's in Queens as well, and he's post in Dentaltown, and he flies to Moscow and throughout the world teaching CEREC, and he says he learned some of his anterior staining techniques, from watching some of my cases, and with composite. He says they teach themselves. So if you learn composite and learn how to use a touch of gray tint for an incisal effect for translucence, that's gonna correspond when you go to CEREC. It's gonna be a lot easier to do a number 8 crown and understand how I can replicate a translucent effect with a gray tint. And then for CEREC, you'd have to, bake it back in the oven for a few minutes. With composite, you can cut into the tooth a little bit and tint it and put a clear shade on top, and you're done in just a few minutes as well.
I know you and I are both conservative as far as tooth structure, and I think one of the human conditions of the mind is everything's extreme. Everything's yes, no, black, white, up, down. You know what I mean? So they'll get a CEREC, and then everything's a CEREC. And it's like and a lot of on the tooth surface, it's a lot more conservative prep if you don't have to prep the thing so indirect draws. You know what I mean?
Right.
So if my prep all doesn't have to draw, a lot of times I can have a more conservative prep. So I think humans tend to be extremist, and I think as you get older and older and older, you tend to be a moderate. And life is really 50 shades of gray.
It really is. It really is. And it really is. I mean, we all see things differently. I mean, between Matt and Artie and myself, we see some teeth a little bit differently. I may see a tooth and I may think it's A1, but I would use maybe a violet and a blue shade for something. And Matt may use a gray shade or a little bit of a violet gray tone. Or Artie may say I'm just going to go just a little gray in that spot. So I mean, we all vary. We all vary, and we're all on that journey together to being the best we can be. But I think we're all meant to kind of have some variation. That's
and a lot of your variation comes from before you were a dentist, you had a love for art. Talk about that.
Yeah, I painted. I went to really throughout high school. I developed a love and passion for drawing and painting, and mainly watercolors. Surprisingly, watercolors are hard. They have a learning curve that's forever. And my art teacher said, Steve, you should learn watercolors. And he says, remember, it takes about 30 of them till you sort of get it. And I could remember being like 15, like this is terrible. But somewhere around number 20, he said, use a hair dryer. And that's kind of a good life lesson is, I had been doing something the same way. You add a protocol change, and all of a sudden, now I can dry that shade and move on. Those kind of things that change in protocol. Now it's different. But that'll always develop your fine hand skills, but it's not nearly as fine actually as dentistry. But it helps. It definitely helps. The other thing though is it can also hurt you. If you have an art background or this or that, you may kind of come in with some ego in some ways, and you think but I can do it. I've been doing art all my life. And you may not listen to the right protocol, and you gotta unlearn some of the things to actually do it correctly. And so you have to go through those things too. One of the things in art for painting and drawing they teach you is not at all right for dentistry. It just doesn't correspond. And that was make your darks dark and your lights light. So if you can imagine, I see a tooth with a little bit of darkness here, a little bit of light here, and all of a sudden I do it, and it's way dark and way light, and so things like that you have to unlearn. But some of the general ideas will correspond. But nothing beats repetition with those people who are maybe kind of doing what you want to do, and they're right there with you. That's where you're going to grow quickest.
So why do you use pencils?
Pencils are really excellent ways to see line angles specifically. I would say line angles for 7, 8, 9, and 10. And then for there's kind of this facial table. It kind of goes up to, about 3 or 4 millimeters from the cervical peak, and then it comes down about a millimeter shy of each side. And you got this table, and you can find it with a pencil. You can just basically draw 2 of them on 2 very curvy, almost like a shells or something. Draw this shape with a pencil, flatten a little bit to that shape, and then carve the other sides. The deflect, that line angle will, when you're all said and done, will be what glistens when you shine light on it from angles. That line angle will be highlighted, and if you can get them to match, you're golden. If you get your incisal edges to look right, and then those line angles to match, even if your shade isn't right, you're still going to match, because your eye's going to find value first, and then contour second, and probably your light reflections are third. So somewhere around 4, 5, or 6 are where my favorite part of them is probably tinting the incisal effects is where that actually comes into a play. But that's where you use a pencil. The second spot is for usually in younger people, you're going to have depressions kind of one in the mesial third, one in the distal third. Newton Fall calls them twin Eiffel Towers. And so you can draw those on with a pencil, and then you can kind of polish into those shapes and make some really beautiful anatomy. So that's why I use pencils. Lastly, a pencil. If you take pencil to your and don't do this unless you're going to put your ego aside. If you take pencil to your composite tooth interface, it's going to highlight with graphite your irregularities, and you're going to have a few marks you thought were perfectly smooth, and they're not smooth, and you gotta continue polishing. So it'll show you your errors. It'll show you contour very well. It's a good tool. I have I think a box of 250 cocktail pencils from Staples, or for golfing pencils. So I just use one and toss it. I think they're 10 cents each, but it takes out,
a golf pencil is also called a cocktail pencil?
I think so.
I've never heard of that.
Yeah, they're small. Yeah. But that way it takes out, did you autoclave that pencil? That kind of thing. So they're once and done. It's wasteful, but it answers it answers OSHA and that kind of thing. But yeah, they work really well. I don't use pencils in the posterior, but in the anterior I use them a lot. Not always, but I use them a whole lot, especially if you can't get, for some reason, the line angle to look just right. We'll put a pencil mark on the adjacent tooth. Now draw that same line on that tooth and repolish that contour a little bit, and then you'll find that line angle just right. Yep.
So you rattle off like 5 or 6 things. You said value. Then can you go through those? Can you go through list those?
Yeah, your value is going to be most important. That's the lightness or darkness of the tooth. If you if you have an A1 tooth and you go C1 or B1, your value is really close. If you have an A3 tooth and you go C1, your value is going to be off a bit. A3 is a lot darker. Your colors, your A's, your B's, or your C's, that's less important than getting the lightness or darkness correct. It's also less important than getting your contour and light reflection fairly correct as well. One of the most believable things to making a front tooth look like it belongs there is if there's a small chip or small irregularity on an incisal edge of the adjacent tooth, to copy it. That'll immediately tell nature that tooth belongs. It's got that same little irregular spot that the other tooth has. And so that's your contour. I know a year ago I left most of my distals a little bit too they needed to get more polished in. And, Matt was, Steve, your distals, you have a tendency to leave distals big. And so, that was always one of the things that stands out. I mean, he could see it right away. And, I've developed the idea to kind of look, you kind of blow your eyes. Okay, the lightness or darkness is right. You don't have to see it all the way to see lightness or darkness. Then you want to look at that incisal contour. If you get that right, and Artie's really good at that. Artie really understands incisal contours and also line angles. And then you want to get your light reflections. And then lastly, there's going to be, your translucent effects and some of your tints and that kind of thing.
And how often do you use tints?
Some I don't. I would probably say on 90% of my larger class 4s, I'm going to use some kind of tint. There's really 3 tints in a class 4. The first would be your more obvious translucent on a young person or on on some older people, but more on a young person. If you see someone who's, 23 and he bleaches their teeth, a lot of times you may see a little bit of a grayish violet tint before the edge of the tooth, and that's a translucent, or you can call it opalescence. Your next tint would be when someone's older, they a lot of times will have a warmer tone on the very edge of their incisal in the middle third of the tooth. So you can use something from Cosmodent like honey yellow just to kind of warm it up a little. Get a little bit of yellow tones that are warm. And then your last tint would be using something that's like a thinned out white. And sometimes I'll use white opaque, John Kanka's Titan, flowable for that. There's sometimes hypocalcifications on teeth, which, adding some white tint or thinned out white opaque, or Cosmonet has a beautiful white tint that's just perfect. And I use that too. That'll mimic that as well. And they're fairly common on edges of younger patients.
You are
right on the edge.
You are so artistic, and I just love it. I only got you down for a minute. I want to ask you a kind of a bizarre question, but
go for it.
When you're doing 6, 8, or 10 on the upper, so I'm not talking about a single where you want to match the tooth. Like you were talking about, the tooth on the right has this little.
Usually I'll do front 4s in a sitting, but if I'm going the canines and premolars, I'm doing that a different day. Front 4 I can focus. That's about 2.5 hours. And then you've had it. That's enough.
But my question was,
Yeah.
sometimes you used to hear more of it back in the day, like in the 80s, but do girls have different shapes of teeth than boys? Are you trying to go, if you're doing the whole upper art, 10 teeth, do girls have different shapes than boys? Do you go softer on canines with girls so that it look like a vampire aggressive, because all apes and monkeys, when they attack with their teeth.
Right.
But do you think that that's crazy and that boys and girls have the same shaped teeth?
Basically, they're the same shape. The difference, though, there are more differences probably between boys and girls. You're probably going to have more differences in ethnicities. I mean, if you're an Asian woman, I can kind of look at your incisal positions and see this very oval type of incisal edges. You'll see some. I think guys might have worn teeth a little more, and so you'll see flatter incisal edges. You'll also see some of the darker shades more so in guys because of lack of whitening and probably home care, maybe more coffee. I don't know, but as a whole, the basics of the teeth are similar.
The basics. Do you see more cases with women? Do women seem to be more cosmetically focused to want to do this as opposed to boys? And what?
I don't know. As probably 10 is to 1, you're going to have women for cosmetic cases over men. And for me too, I kind of mark it, where I'm not going to drill teeth, so maybe that even makes that even further, where it's women maybe see that and say, I want to get something done, but I also don't want to have someone drill my teeth, and they may find me on a website where I say I rarely have to adjust teeth very much with to move tooth structure to do these cases. So I may even select it out further, but I've only done composite veneers on one guy. I've done a composite bridge, which is like 3 composite veneers on another guy. So I mean, that's 2 cases out of probably 30 cases that have been on guys. I have one friend who needs some composite veneers. He's a guy, but he's got these lines in his teeth and bonding irregularities. I don't think he is in a hurry to fix it. I think a woman who's cares. I think women know their eyes are the center of their upper face and that their teeth and lips are the center of their lower face. And you have your eyes looking right, your teeth looking right, you're going to have a nice face. But I think guys just don't care.
I mean,
not nearly as much.
I'm a dentist for 28 years, and every single picture I ever see of myself, I don't even show any teeth. It looks like I left my denture at home when I look at my pictures. That's kind of ironic. But hey, we're at an hour or two, but I just want to sit there and say that, dude, it was an honor that you gave me an hour of your time. I'm the
sure thing.
fan of your post. I hope you have Matt do one of these too. I feel it's my duty to make sure that most people are exposed to you. If you want to, whatever you want to do with Dentaltown, I mean, if you want to do Townie or you want to do other courses, anything I can do to help you, because I think the more people that get turned on to you and Artie and Matt are they're gonna fall in love more with their profession. It's gonna be more of a vocation instead of occupation. I just think you're doing wonderful things for the profession of dentistry. And on that note, thank you so much for an hour of your time, and I will see you on the boards. And me or Hogo or both are gonna see you October.
October 10th, Saturday.
Saturday, October 10th. And again, thank you for all that you do, buddy.
You got it, Howard. Thank you so much.
All right, bye-bye.